Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Nicole Ricino. Today's episode features expert discussion on the role and safety of bispecific antibodies for the treatment of relapsed/refractory multiple myeloma. Dr. Caitlin Costello from the Moores Cancer Center at the University of California, San Diego in La Jolla, California, will tell us about these bispecific antibodies and also provide some key clinical pearls for how we can use these agents in clinical practice. This episode is part of a larger educational program titled Refining Therapeutic Approaches in Relapsed/Refractory Multiple Myeloma, Expert Guidance on Bispecific Antibody Therapy Optimization. For more information on Dr. Costello, along with a link to the larger education program, please visit the show notes for this episode. Now let's get started and hear what the expert has to say about this important topic.
Hi, my name is Caitlin Costello. I am a clinical professor of medicine at the University of California, San Diego at the Moores Cancer Center, and I'm delighted to be here with you all today to talk a little bit about bispecific antibodies in the field of relapsed and refractory multiple myeloma, and hope to be able to offer some background information on bispecific antibodies, think about some kind of key clinical pearls that perhaps may make the transition in your practice, if that's what you're trying to do, to offer these for our patients. And maybe even think a little bit about some of the upcoming trials or emerging data that is supporting these bispecific kind of platform to be able to continue to improve them. So without further ado, I feel like it's probably a reasonable approach for us to start off just to make sure we're all on the same page with some background information about bispecific antibodies. Here today in 2024, we have 3 bispecific antibodies that are approved for the treatment of relapsed or refractory multiple myeloma. 2 that are targeting BCMA, 1 that is targeting GPRC5D. Now, remember, these are both antigens on the plasma cell surface that really have very limited antigen expression off of the plasma cell, which really makes them ideal targets to make sure that we are getting kind of the maximum effect on tumor and the minimum effect off tumor, but on target, if you will. So thinking a little bit about these bispecific antibodies, they were approved for the treatment of patients who had had more than 4 prior lines of therapy for relapsed refractory myeloma. So these are your patients who have had proteasome inhibitors, CD38 monoclonal antibodies, immunomodulatory agents, oftentimes what we would call those triple-class refractory patients or perhaps the penta-refractory patients. These are patients that really have had such a great unmet need. And in the past couple of years, the development of CAR T-cell therapy and now bispecific antibodies have really offered an exciting 2 classes of drugs, really, that have seen really unprecedented responses and survival outcomes for patients who previously had really kind of unfortunate but dire results with the standard of care therapy. So really excited, I think all of us are, to be able to offer these therapies to our patients because of these improvements that we've seen in this treatment landscape. So bispecific antibodies, the 2 that target BCMA that are approved and currently on the market are teclistamab and elranatamab. Both of these target BCMA. They both have some reasonable follow-up data now where we can see, good overall response rates, some at least beginnings of progression-free survival, and certainly a better understanding of, safety and toxicity. I think broadly, when patients are choosing and you are working with them to kind of strategize a little bit about who the right candidate is for a bispecific antibody, whether that's a BCMA target or a GPRC5 target, a lot of patients probably are candidates for both to some degree, but some of the reasons why we may choose teclistamab or elranatamab as examples would be, perhaps we're worried about the CAR T CRS or ICANS or some of these delayed neurotoxicities that we've seen with cilta-cel as an example, and perhaps your patient is older or frailer or has some neurologic baseline side effects that make you worry about exacerbating them. Perhaps a bispecific could be an option there. It's a little bit more controllable, meaning that have these, step-up dosing approaches where perhaps you can control the CRS, delay additional therapy if the CRS is more significant. Perhaps another good role for bispecifics, however, is really based on the biology of disease. If we see that these patients have very aggressive relapse, waiting for CAR T cell authorization from the insurance company and collection and manufacturing time, there are a lot of patients who can't wait for that, and has led to a lot of attrition on trials and unfortunately early death sometimes. So we have to make sure that we are, offering the patient the most effective therapy as soon as we can. And perhaps those patients with aggressive relapse would benefit from bispecific therapy because it's off the shelf and we can quote unquote do it tomorrow. So teclistamab, elranatamab are examples of that, where if your patient has never had a T-cell engager of some sort, and you're worried they're not candidates for CAR T for whatever reason, and or they have aggressive relapse, this might be a good option for them. Teclistamab, elranatamab, I think some places have each on formulary, some have chosen to have one. There's maybe subtle differences in terms of how the step-up dosing has been approved by the FDA. However, I think you can, to some degree, generalize and say that these two drugs both have overall response rates that range in the 60 to 70% range or so, and really understand that the safety profile is what is expected. CRS and is kind of the most common initial side effect we can see with these drugs. Most common kind of in the trials and what we've kind of seen in real world in our practices is that, CRS may happen, but it's not going to probably be very, very high grade. Most of these patients have grade 1 or grade 2, and with early intervention with, medicines like tocilizumab, for example, we can stop that pretty quickly to allow the patients to get the full step-up dosing. So, it does require, one of the questions I frequently get asked is, how do you do this? And what kind of pearls do you have for me associated with that? And, I think many of the academic centers have started off with doing step-up dosing in the inpatient, setting, but it's a little full in the inn these days. And so there's lots of interest in transitioning these patients and their step-up dosing to that outpatient setting, of which I would say, regardless of where you are, this is a bit of a team sport. Just like with our CAR T treatments, we really need to make sure we have all of our, team members ready to go. And this includes obviously the physician and the advanced practitioners, but most certainly our pharmacy and nursing colleagues just the same, to make sure that everyone has an understanding of what their role is in this process. And sometimes that extends beyond kind of the nucleus of the hematologic team, if you will, and extends into our infection specialists or our neurology specialists, critical care specialists. So really making sure that you have that infrastructure set up in place so that we can support the patient for what are common side effects, but also preparing for what are less common side effects. So whether inside or outside, first pearl is make sure you have your team in place. As part of kind of the FDA label, we have to all have tocilizumab ready at our disposal to use. I think it's 2 doses on hand. And these patients, when they are getting their step-up dosing, whatever drug you're choosing are, as I explained to my patients, small dose and hope for small reaction, such that the body then becomes a little bit acclimated to the drug, where when you're giving the next dose, perhaps the body is used to it at that point, and the likelihood for a reaction is lower or perhaps none. So that once we get to what we call target doses, the patient is less and less likely to have kind of CRS or cytokine release syndrome. Remember, I think as part of preparing for step-up dosing and those reactions is that these are heavily, immunocompromised patients who've had a lot of treatment previously. And, while the fever, for example, in the midst of step-up dosing is probably because of cytokine release syndrome, don't forget that they are at such high risk for infections that you need to make sure you are thinking about it. These patients with infections should be cultured. They should be, evaluated for an infection, perhaps given antibiotics for prevention or for treatment if something is found. But a high level of suspicion for an underlying infection in the midst of a fever for someone who is immunocompromised obviously is critical. Awareness for neurotoxicity is a big part of this. I think just the same, it's not as common as we see it in CAR T cells, but it's not a zero chance. It's a low likelihood, but making sure that you are prepared that your nursing staff or whoever is evaluating patient is able to objectively evaluate these patients with our ICE scoring system as a way that we can understand if the patient is developing ICANS, and being prepared with your dexamethasone. And, I've started off here with BCMA specifically, but I think it's reasonable to say that this applies to all these bispecific antibodies. We know that the BCMA targeting group of bispecific antibodies does seem to be slightly more associated with infections. So relative to the GPRC5D bispecific antibody called talquetamab that is improved, has a kind of different set of common side effects that I'll touch on in a moment. But I think for the BCMA targeted ones, really make sure that you are thinking carefully about getting patients through their step-up dosing and thinking of ways that you can mitigate risk and minimize those infections. So supportive care is a big part of this. When thinking about getting the patients through their initial step-up dosing, make sure you're remembering, and this is a good pearl, that all these patients' T cells are really being pressured to work hard to fight the myeloma. That really kind of leads to some significant level of exhaustion where we can see lymphopenia can be significant. And these patients are at risk for a whole slew of different infections that, previously we've kind of thought were confined to our patients who had undergone allotransplant or, immunosuppressed for other reasons, but seeing some unusual viral reactivations, more PJP as an example, and ways that you can mitigate against that include really regular and routine use of IVIG. I think many of us myeloma docs have been used to giving IVIG for patients when they had, quote, recurrent severe life-threatening infections. But I think for these T-cell engagers in particular, it really makes sense to be preemptive. And after they're getting through their step-up dose, and perhaps start IVIG as a preemptive approach once a month thereafter. Make sure you're thinking hard about what the right prophylaxis is otherwise with your antivirals and your antibiotics, anti-PJP coverage. Sometimes patients will come to the academic center for their step-up dosing and go back to their community oncologist. And, that handoff will be a critical component of that to make sure that there's a seamless transition with all that supportive care once the patient has gone through that window of CRS and ICANS as an example. I think let's touch a little bit on GPRC5D next. Remember, this is the second antigen that can be targeted by bispecific antibodies. It's the only currently approved T-cell engager that targets GPR is called talquetamab. Talquetamab targets GPRC5D, which, as mentioned previously, is really nicely expressed on the plasma cell surface. But some off-tumor expression occurs in kind of epithelial cells, such as hair and skin and nails, and to some degree kind of in the tongue. And that off-tumor on-target effectiveness, if you will, that happens there is what leads to some of these new side effects that we really need to make sure that we are prepared to manage. So patients receiving talquetamab are likely to develop side effects that are unlike what we've seen with kind of traditional myeloma therapies, where these patients really can develop dysgeusia, a loss of taste, dry mouth is common. Both of those things result in a loss of appetite and weight loss very commonly. Besides that, some patients can have some changes in their skin that can range from dryness to actual complete desquamation of their palms and their soles, and can really see some ridging and cracking of their fingernails. So, I think many of us are trying to figure out the best approach for the supportive care of these particular side effects and the profile of this drug. And I'd like to say I know the complete magic fix to this, but I think some of the tips and some of the pearls we've learned for management of this is the importance of emollient creams for the skin, for example, and the nails, making sure that you are, increasing hydration as best as you can for the mouth. Perhaps some dexamethasone mouthwashes can be helpful, confirming that there's no fungal infections with thrush, as an example, in the mouth. But I think probably the best supportive care option here is that if patients are really starting to develop those side effects, is lowering the dose or perhaps extending the interval between doses. And this is an approach that can be used with all these bispecific antibodies, really, is if we see that we have a lot of infections with the BCMA or the GPR bispecific antibodies, or the dysgeusia and hair and nail changes are significant, then lowering the dose, spacing out the dose is the right approach. We think that spacing out the dose, for example, allows those T cells to recover a little bit, perhaps protect the patient a little bit more, and allows the patient's taste buds and skin to kind of recover as you kind of continuously give them these drugs that are leading to these side effects. So You can do a lot of different supportive care measures, but perhaps the best thing is extending the interval or lowering the dose. And I think we'll figure this out. The FDA has really put out initial label instructions that gives a very specific calendar of dosing of how to administer these drugs. But I think, as we always do with myeloma drugs, is we figure it out as we go along. And a lot of drugs end up being spaced out, or perhaps they don't need as frequent as a drug that was studied, or they don't need as high of a dose that was studied. And I think the future of what's coming with a lot of different trials and some of this emerging data is how to perfect it, both in terms of improving the safety profile, but in terms of improving the efficacy as well. So as we're moving on to kind of thinking about how we can improve or perfect what we're already doing, lots of kind of the emerging data and clinical trials that are ongoing are looking at combinations. We've learned a lot about single agent activity with these drugs and understanding that they work 60 to 70%, overall response rate, which is great compared to the historical, bar that was, thrown down, the gauntlet that was thrown down at 20 to 30%. But really want to figure out how we can perhaps ripen the immune system to function better, to really synergize, if you can, with the bispecific antibodies just the same. So a lot of the trials now are looking at combining these bispecific antibodies with our old faithfuls, looking at combining it with daratumumab as an example, looking at combining it with some of the immunomodulatory agents. We heard recently about combinations about talquetamab with daratumumab and or pomalidomide, and really trying to understand how we can safely do that to improve effectiveness. There's also interest in looking at combining bispecific antibodies as well. We've seen teclistamab and talquetamab studies that are combination studies, looking at how we can kind of benefit from targeting both targets at the same time. Again, hoping that there's not significant overlapping toxicities, particularly with infections, which we're worried about. But, understanding that if we can hit both, perhaps we're going to really attack that plasma cell in a more effective manner. And a lot of these trials obviously are being done in the late line, later relapse, but there's certainly quite a bit of interest in, if they work so well in late relapse, should we be withholding them and consider using these patients in early relapse, and some trials that are looking at using them in the newly diagnosed setting. And so I think there's a lot of interest to understand how we can introduce these new tools into our ever-expanding arsenal, but how to do it in a safe and effective way that are going to give patients the deepest and the most durable response. And that bar is pretty high. What we do right now is pretty darn good. I do personally worry that there's, a pretty high tolerance for side effects with patients who have, minimal alternative options for treatment. They say, bring it. If it works, I'll deal with the side effects. But, for patients in early relapse or first diagnosed, we need to make sure that we are obviously doing no harm and maintaining quality of life while enjoying the successes of treatments. And so I think that will remain to be seen to understand exactly what the role of bispecific antibodies will be in earlier lines of therapy and certainly in the newly diagnosed first-line settings. So there's a lot of excitement in terms of what is happening with the introduction of bispecifics antibodies into the treatment landscape in general, and really trying to hone in on the best way to use them the most successfully and the most safely. And while we have 3 of them that are currently approved, there are several more that are in the pipeline that are also new drugs, some that are targeting BCMA, however, some that are targeting and looking at other antigens. Cevostamab, as an example, is one that is coming down the pipeline. We've learned a little bit about is FCR targeting. We're going to learn more about what targets are the right targets, what sequence is the right sequence. Should we be doing CAR T cells first? Should we do them bispecific second, or vice versa? And who the right patient is to use bispecifics on from the get-go. So I hope this has been helpful to really kind of provide you with what the current state is in terms of what is going on in the field of bispecifics for the use of treatment of multiply relapsed and refractory myeloma, and hopefully provide you with some pearls about the best supportive care for these patients, and help you think a little bit about how to choose one drug versus another when you're in with your patient in clinic and trying to understand what the best approach is for them based on the patient, their comorbidities, the biology of their disease, their support system, the aggressiveness of their relapse. All of these criteria are such important factors when you're considering the next line of therapy. And lastly, kind of what's coming next, looking at combinations, looking at combining good oldies with new drugs or new drugs in combination together, and really understanding how we can keep our patients safe, great quality of life, but enjoying, really nice progression-free survivals with these new class of drugs. So I'm very grateful for your time and energy to listen to this, and really hope this has been helpful in your clinical practice.
Thank you, Dr. Costello, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Refining Therapeutic Approaches in Relapsed/Refractory Multiple Myeloma, Expert Guidance on Bispecific Antibody Therapy Optimization, please click the link in the show notes. And be sure to check back regularly for more episodes on important oncology topics.